why don't we go ahead and get started. Welcome everyone to the April 8th edition of Nephrology Grand Round at the University of Washington. We have Dr. Yue-Harn, who will be launching Grand Rounds this morning, followed by our monthly biopsy conference. I was going to ask Dr. Aurora to provide us an update on how our Neph Madness bracket is doing, but I don't see him here, so maybe we can get an update at a later point. I did see in the bracketology that social determinants of health has made it through to the final matchup, which is one of our final matchups, although our other final matchup or category, which was kidney biomarkers, I think did not even make it through the first round. So that's not a good sign. All right, without further ado, Dr. Ng, go ahead.
Here you go. All righty. Good morning, everyone. For Grand Rounds today, I thought I'd talk a little bit about health literacy and kidney disease. And before I start, I'd like to do a poll on how many people actually assess for health literacy in their clinical practice, whether it's first visit or subsequent visits. All righty, cool. I like this actually. So it looks like it's a good hodgepodge. There are some people who do it a lot, but a very good mix of everything. So I think this is a very nice topic to talk about. And I'd like to start by sharing with you a very humbling experience that I've had. Somehow, let me just advance it. All righty. So Mr. S is a 60-year-old gentleman with a past history significant for diabetes, hypertension, end-stage kidney disease, presumed to be secondary to diabetes, had been on hemodialysis since May of 2017. I met him when he came in for a kidney transplant in October 2020. And his transplant course was actually fairly unremarkable. So he underwent a deceased donor kidney transplant. The only complication he had was he required 1 session of dialysis for hyperkalemia. But he did really well after that. And we were getting him ready to be discharged. And it was then that the nurses and the pharmacists came and started telling me about their concerns for this patient. So according to the report from the pharmacist, this patient was unmotivated to learn about his medications. He just wanted to rush through teaching and push to get through things more quickly. So the pharmacist said that they were able to get through all the information, but they called and spoke to his nurse and asked them to reinforce the medications and the timing even further. And in the nursing report, it was stated that this patient did not understand his medications, even with using a Punjabi interpreter, and he was unaware of the importance of certain medications, timing, and lab drawers. 1 hour was spent with the patient going over his self-administered medications. So because of these reports and concerns, we actually kept the patient in the hospital longer and arranged for more teaching sessions with the nurses and with the pharmacist, as well as with his family. And it seemed like, we were making good progress. So we were getting ready to discharge the patient. Prior to discharge, the nurses said, he's able to perform most of his self-administered medication tasks with moderate assist. So he seems to be able to pick out his medications going down the list. They printed out a medication list in Punjabi, for the patient, but the patient said he wasn't able to read it well because he didn't bring his reading glasses. So very naively, we encouraged the patient to remind his son to bring his reading glasses in so that we can assess him. The son brought the reading glasses in. We have all the materials, the teaching materials in Punjabi, and we were getting ready to discharge this patient. So on the day of discharge, on the day before discharge, I walked into the room with my whole team, with the nursing staff, in front of the family members. I took up the medication list in Punjabi, and I asked the patient to read out what his medications were and how many times he was supposed to take. And I essentially forced this patient in front of everyone to admit to me that he actually couldn't read. So of course, there was very awkward silence after that. And me as the attending, I was extremely embarrassed because I embarrassed this patient in front of everyone. And I was also very embarrassed because I actually I failed to recognize all the red flags that showed that this patient not only had poor health literacy, but actually had fairly poor literacy as well. So what did I learn from this lesson? I learned never to assume that our patients can read and write, and everyone will actually benefit from very simple, clear communication, regardless of what their education level is. So after this experience, I wanted to learn a little bit more about health literacy. I wanted to know how common is inadequate health literacy in our kidney disease and kidney transplant population. I wanted to know what tools are available to assess health literacy, and what is the impact of inadequate health literacy on kidney disease and kidney transplant? Why should we care? And what are some of the interventions that are available to help patients with inadequate health literacy access kidney transplant? So to start off, what is health literacy? The Institute of Medicine basically defines health literacy as the degree to which a person can obtain, process, understand, and communicate about health-related information so that they can make a medical decision. So it's really a mouthful, but basically what literacy is a hodgepodge of the ability to listen and to speak, which can comprise of oral literacy, the ability to read and write, which is printed literacy, but it also has a component of numeracy, which is the ability to use numbers, to understand and apply numbers in order to make medical decisions. And all this has to be taken in the context of the appropriate culture and the appropriate conceptual knowledge. So if you think about it, medical self-management is actually a fairly complex process. Not only do our patients have to understand why they're taking the medications, they have to be able to organize their medications, into however many times a day we want them to take, once a day, twice a day, 3 times a day, and sometimes even 4 times a day. They have to take these medications, monitor how much is left, and then remember to refill before they run out of their medication. So it actually is a fairly complex process, and it's really our responsibility to be able to communicate all this information to our patients in a way that they can understand. And the other thing is, the CMS ESRD condition for coverage actually also says that every patient actually has a right to receive all information in the way that he or she can understand. So it is estimated that actually up to 1/3 of adults in the US have limited health literacy. And these individuals with limited health literacy has been associated with poor blood pressure control, increased hospitalizations, low self-management of chronic disease, and all of these are risk factors for kidney disease progression. So it's actually not that surprising that our kidney disease population has a high number of patients with inadequate health literacy. In this systemic review paper that was published by Taylor et al. And C. Jason in 2017, the authors gathered the literature on health literacy and kidney disease up to the year of 2016, so a total of 20 articles. And what they found is in the non-dialysis CKD population, inadequate health literacy was present in about 25% of the population. In the dialysis population, this number is similar, maybe a little bit higher at about 27%. And in the transplant population, this number is about 13%. So if you're wondering, why is this number lower in our transplant population? Well, let me explain to you why. So when our patients are diagnosed with kidney disease, we send them for dialysis education, and we also refer them for kidney transplant. And what you will see here is during the kidney transplant process, it's not really a one-time, one-day process. It actually is a pretty iterative process, a pretty repetitive process. So they come in, we tell them they have to do tests, and depending on what their test shows, we may tell them they have to do more tests. And during that time, we may discover something new. So then we tell them they have to do this other test. And so this thing just goes on and on until they're able to fulfill the requirements that we have of them. And finally, we say, yep, you're good enough to be put on the kidney transplant waitlist. And on the kidney transplant waitlist, they have to try very hard to not get taken off the waitlist or die during the wait while waiting before they would get a kidney transplant. So in this paper that was published by Scholl et al. In C. Jason in I think it was 2011 or 2012, the authors found that out of the 3,000 patients who were evaluated at the University of Florida for kidney transplant, only about 56% of them actually make it to the evaluation and get through the transplant workup process. And of this 56% of patients, only about 27% make it to the kidney transplant waitlist. And of this 27%, only about 17%, it's actually 17% of the total population, only about 17% of them make it through kidney transplant. So what you can see here is the attrition rate is very high. And many of our patients actually get denied. They fall through the cracks and they get lost to follow up during this process. So this is a paper that was published by Petzer et al. Looking at all the different barriers to kidney transplant in our CKD population. And what you will see here is transplant, having the necessary transplant knowledge, having health literacy is necessary for almost every step of the transplant evaluation process. So therefore, it's not that surprising that patients with poor or inadequate health literacy many times don't make it through the transplant process, don't get waitlisted, and don't get transplanted. So first things first, how do we recognize a person with an inadequate health literacy? So there are assessment tools available. And one of the most commonly used tool is this test called the Rapid Estimate of Adult Literacy in Medicine, or the RELMS test. It's one of the first measure, and it's actually one of the most frequently used tools to assess health literacy. It's actually fairly brief. It takes about 3 minutes. And it's a list of 66 words that the participants have to read aloud, and they're assessed for their pronunciation accuracy. So it doesn't actually assess a person's understanding of the words, it just assesses their ability to read out the words. So it's literally an assessment of oral literacy. There's a kidney transplant version called the RELMS-T, which composed of 69 transplant specific words, and it's actually validated in the kidney transplant recipients. So this is an example of the RELMS test. So as you can see here, it's 66 words. Anyone who scores 61 to 66 is considered to have adequate literacy, which is equivalent to 9th grade or greater. 45 to 60 is marginal literacy, which is equivalent to 7th or 8th grade. And anyone with a score of less than 45 is considered to have low literacy, which is equivalent to 6th grade or lower. Other tests that are available are tests like the test for functional health literacy in adults, or the TOFHLA. It's also fairly commonly used, more often used in research than in clinical practice. And what it does is it assesses a person's comprehension of a text. So the person has to read a text and in which every 5th to 7th word is missing. So it tests the person's understanding of the text and the context in which they have to understand enough to find the missing word to replace it. A complete test consists of 50 items and takes up about 18 to 22 minutes. So as you can imagine, in a very busy clinic, it's not always easy to do this test. And the complete version also has 17 numeracy items in it. But more often than not, people usually do a shortened version, the TOFHLA, which consists of 36 items and usually takes up about 7 to 10 minutes. It has 4 numeracy items in it, but many people actually take it out because it's often eliminated. It's not found to contribute additionally to health literacy assessment. So this is an example of the TOFHLA. So anyone who scores 67 and above is considered to have adequate literacy. 54 to 66 is marginal literacy, and less than 54 is low health literacy. Now, if you think about it, these tests actually, they assess a person's ability to read and ability to understand, which in a person with low health literacy can sometimes seem a little bit demeaning and embarrassing to the patient, especially when they actually can't read. So there are some other tools out there that are a little bit more forgiving. So there are tools like this brief health literacy screening survey, which is actually developed here at the VA in Puget Sound in their pre-op clinic. So they assessed 16 screening questions and validated them against the TOFHLA. And questions such as, how often do you have someone help you read hospital material? Actually has an ROC curve of about 0.87. How confident are you in filling out medical forms by yourself? Has about a 0.8. And how often do you have problems learning about your medical condition because of difficulty understanding written information? Has about 0.76. So gathering some of these questions that have high ROCs, there are these surveys out there where you can ask your patients these questions. It's usually around 3 to 4 questions. Some have 3, some have 4. And if anyone answers 3 or less, so sometimes, often, always, and it is indicative of inadequate health literacy. But this tool is actually not very sensitive against marginal literacy. So if you look at these different tests, of course, there are more tests out there, but these are 3 of the most commonly used tests. Each test has their own pros and cons. And the realm, being one of the oldest and most commonly used one, has been translated and validated in many different languages. So what is the impact of inadequate health literacy on kidney disease outcome? One of the most cited and oldest paper is this paper by Carrie Cavanaugh and Jason in 2010. The authors assessed 480 incident chronic hemodialysis patients from 77 dialysis clinics between 2005 to 2007 and followed them until 2008. The health literacy was assessed using realms, and in this population, they found that 32% of the patients had limited health literacy. And in patients with inadequate health literacy, they were found to have higher mortality compared to patients with adequate health literacy. Now, you may ask, well, why would that be? Why would someone with inadequate health literacy have higher mortality? And we may find the answer in this paper. So this is a paper that was published by the Pittsburgh group in AJKD in 2013. They assessed 260 maintenance hemodialysis patients who was enrolled in another trial. And they assessed them for health literacy, again, using the realm. And the outcome that was assessed was dialysis adherence and healthcare resource utilization, including emergency room visits and ESRD-related hospitalization. And one of the most obvious things you will notice is people with adequate health literacy and people with inadequate health literacy are not exactly the same population. So patients with inadequate health literacy tend to be Black Americans. They tend to have lower education level, lower income, and higher comorbidity. So off the bat, we realize that patients with inadequate health literacy definitely are more vulnerable compared to patients with adequate health literacy. And I suppose it's definitely not that surprising that they have more dialysis non-adherence and more healthcare utilization, including emergency room visits and hospitalization. In this population, though, the percentage who underwent a kidney transplant or died was not that different. So what about kidney transplant? So this is a paper that was published in AJT in 2019 from Johns Hopkins. The authors looked at 1,578 adult kidney transplant candidates who were assessed in their kidney transplant clinic, and they assessed them for health literacy, for frailty, and for cognitive function. And in this study, health literacy was assessed using the BHLS, so the survey that I talked about earlier. And again, what you will see is patients with limited health literacy have less college education, they're more frail, and they have more cognitive impairment. So again, the population is very different from those who have adequate literacy. And in this population, patients with inadequate health literacy have a lower probability of kidney transplant waitlisting and a higher probability of waitlist mortality. So what about the few? What about the few patients who actually make it through kidney transplant? What happens to these patients? So in this paper that was published by Petzer et al. In 2016, they interviewed 99 adult kidney transplant recipients and assessed them for risk factors for non-adherence, for their treatment knowledge, and also assessed kidney transplant outcomes such as hospitalizations, acute rejection, and infection. Health literacy in this study was assessed using realms. And what they found is patients with limited health literacy have higher risks of self-reported non-adherence to medication. The gratifying part about this study is patients with limited health literacy post-transplant actually have similar hospitalization and mortality rate, but there definitely is less adherence post-transplant. So why should we care? Well, what I've shown you so far is inadequate health literacy is associated with, in the CKD dialysis population, non-adherence to dialysis, increased healthcare utilization, including hospitalization and emergency room visits, increased mortality, and they also have decreased access to kidney transplant referrals as well as waitlisting. In the kidney transplant candidate and recipient population, inadequate health literacy is associated with increased kidney transplant waitlist mortality, decreased kidney transplant, and also increased non-adherence post-kidney transplant. So as a healthcare provider caring for patients with chronic kidney disease, it is our responsibility to help improve the outcomes of this patient and also help them achieve the best outcome possible. Another reason why we should care is, in this paper that was published by Vanessa Grubb in 2009, the authors showed that if given a choice, most of our CKD patient or dialysis patient would choose kidney transplant. In this population of 62 patients who she interviewed, 90% of them would prefer kidney transplant over dialysis. So as a healthcare provider, it is our responsibility to help our patients achieve the best outcome possible. And another reason why we should care is health literacy literally is one of the main determinants of healthcare inequity. So this is the same paper that I showed you, the systemic review. And Taylor et al. Basically showed that inadequate health literacy is associated with multiple determinants that are associated with healthcare inequity. And that includes old age, non-white race, not ethnicity, low income, low education level, and higher comorbidities. So in our efforts to try to address healthcare inequity, we need to be mindful that we need to address health literacy in our efforts to improve healthcare equity. So how do we do that? So basically what I've shown you so far is there are many factors that go into a person's literacy status, whether it's health literacy or literacy. It includes age, their education level, their income, their employment, their race. And it's the level of health literacy that will inform a patient's ability to make decisions, their ability to solve problems, advocate for themselves, and communicate their desires to their providers or within the healthcare system. If the person is not able to do it, they often rely on their caregivers. And it's this patient-caregiver interaction that will then interact with our healthcare system and our providers that will ultimately determine their outcome. And in my world, that outcome is kidney transplant waitlisting, their ability to get transplanted, their allograft survival, and patient survival after transplant. So as you can see here, there are multiple areas that we can try to target when trying to address the health literacy of patients. Obviously we can address it at an individual level with patient education, We could address it at the caregiver level or interpersonal level by providing peer navigators or help during the process. Or more importantly, we could also address a health system, address it at a health system level by changing policies and providing more resources. As an individual physician, I think what we can do is recognize, screen and recognize our patients with inadequate literacy. So this is a slide that I took from the AHRQ Health Literacy Toolkit. So recognizing some of the red flags for low health literacy. So frequently missing appointments, incomplete registration forms, non-adherence, unable to name medications, unable to give coherent sequential history. There's been so many times we've heard of, this person is a poor historian. Well, maybe he's a poor historian because he has poor literacy level. Asking fewer questions and not following through with tests or referral. And I'm sure these are very common things we see in our day-to-day care of our patients. So recognizing that these may be signs of inadequate health literacy is very important. But I would suggest that we actually take one step further and basically use universal precautions for health literacy. So structure our care as if everyone has low health literacy, because really sometimes you just can't tell. Always use easily understandable instructions, focus just on the need to know and need to do, and ask patients and caregivers how they're going to follow through with the treatment instructions. So use teach back as much as possible. If you have to give written material, avoid medical jargons, use a 5th grade reading level or lower, large fonts, small increments of information, and try to be as culturally appropriate as possible. But on a systemic level, so that's what we can do on an individual level. On the systemic levels, there are some studies that have been shown to improve access to healthcare for patients. So this is a study that was published by the UCLA group. They randomized 802 patients who were pursuing transplant at UCLA to 2 groups, one an education program group called the Your Path to Transplant, and the other one is the standard of care arm. So those who were randomized to the education program had coaching sessions at 4 different time points: at baseline, within 2 weeks of randomization, at 4 months, 8 months, and they were assessed for outcomes at 18 months. And during each of these time points, the patients would be coached about kidney transplant, and they will also be assessed for their readiness for kidney transplant. And what they found is after these coaching sessions, these patients who were in the education arm had better transplant knowledge, and they also had more readiness for kidney transplant. And at the end of the study, the intervention group also had a higher probability of being waitlisted compared to those who receive standard of care. Now, I do recognize that this process is fairly labor intensive, but it does show that it has good outcome, although I am also cognizant of the fact that in order to sustain a program like this, we need to be invested, and the institution needs to be invested in helping these patients. So what I've shown you so far is inadequate health literacy is very common in our chronic kidney disease population. Assessing patients for health literacy and providing information that the patients can easily understand is the responsibility of the medical community. Interventions aimed at assisting patients with kidney transplant workup may increase their access for the patients with inadequate health literacy. And policies to address structural racism and provide additional resources to patients with low social determinants of health can address issues associated with healthcare disparities. I'm happy to take any questions.
Thanks so much, Yue-Harn. Have a few minutes for questions.
I'll ask a quick question. Yue-Harn, that was amazing. I feel like I learned a lot. One of the things, just in terms of practicalities, I saw on one of your slides where one suggestion was to aim for a 5th grade level or lower. I know I've heard a lot about aiming for 6th grade level or lower. Is that felt to capture a certain percentage of patients? Was that just kind of pulled out of the air, or, how did people come up with that? And is that felt to be a reasonable, it's hard to use something that's one size fits all. So I'm just curious of your perspective on that.
Thanks for the question, Suzanne. So, most of these health literacy tools, in terms of, assessing patients, the literature suggests that in order for a person to go through the healthcare process, in order to understand the information that we give patients, it has to be at a 9th grade level, which means a lot of our patients won't understand. So what a lot of these health information tool aims at is lowering that level so that you try to capture as many patients as possible in language that as many patients understand as possible. Of course, it doesn't capture the ones who are illiterate, who never go to school. So I think we need to do better. We definitely need to do better.
Questions? All right. Thanks so much, Dr. Ng, for a wonderful talk.